design of case control studies, including including some detailed examples on the topics of selection bias and also the timing of recruiting the controls versus the cases as just two examples of types of bias that we've investigated, and maybe methods that either we have used or our collaborators have used that may be interesting to you as you're also doing your own work. And so case control studies, this is a kind of definition of case control studies. So here we're comparing the past exposure histories of cases, so people with the condition of interest, versus those who are free of the condition of interest at the time that the cases occurred. And, as Neil was describing, they're often conducted as a convenient alternative to cohort studies. They can be definitely more cost efficient by conducting oftentimes much more detailed exposure assessment on the cases and controls versus conducting a detailed exposure assessment on everyone in a large cohort study, where many will not go on to develop the disease of interest. So they are very useful in occupational epidemiology for this reason, for the ability to collect very detailed information about job and exposure information, usually much more detailed information than cohort studies usually. And they're very useful for diseases that are rare or have a long induction time. So for example, even if you have a cohort of 1 million people, and you follow them for 20 years, you may get very few cases of rare diseases in that cohort. And so going to another design here, case control design may be very useful. So this is just one example. This is just a random example of a case control study. This study was conducted in the United States. And I just wanted to point out, the level of detail that you can go to when you're conducting your exposure assessment. So if you were invited to participate in this study, you were mailed a work history calendar. So you had to list each job you held for at least 12 months since you were 16 years of age, and also the name of the employer. So, just doing that, I think, would take me a while to think of every single job I had since I was 16 years old, where I was and who was the employer. And so that's already, I think, some level of burden for the participants. Then after that, there was a home visit by a trained interviewer. And so this interviewer asked much more detailed information on each job, including the number of hours worked per week, the type of business it was, the tasks that they had done, and a description of the chemicals and equipment that was used in their job. And then after that, if you had worked in one of 39 different specific jobs that they were very interested in here for solvent exposure, then you were invited to complete additional detailed modules on the type of solvent used, the frequency of solvent-related tasks, were you working indoors or outdoors? What was the ventilation like? What was the mechanism of solvent release? How close or far you were to the chemical? What was the temperature? How much dermal exposure you had? And then it could be that maybe you had more than one of these important jobs, but the interviewers only asked you up to 5 different modules to each person to minimize the burden on the participants. So it's just an example just to show you, what kind of detailed information that you can capture from people, but also at the same time that it is a lot of work for the people that participate in the study and for the interviewers to conduct these very long, detailed interviews. And so when we're thinking of defining cases in case control studies, often people will take a look at what the definitions were used in previous studies, either to be comparable to previous studies or to do something that's maybe improved to previous studies. In some cases, it can be very easy to define what your case is. For many counselors, it can be fairly easy to come up with your case definition. For other types of endpoints, it can be more complex. So when we're thinking about doing research on burnout, for example, how do you define burnout? How is it defined in different countries? And how would you find cases that have burnout? So different things to think about when you're defining your cases. So this is just one example. So this is a case control study that I'll use for different examples throughout the lecture. This is a case control study that was conducted about 20 years ago. The original purpose of the study was to look at mobile phone use and brain tumors, but there was also a large occupational component to it as well. So here you can see, if you go to this is the original manuscript showing the methods of the case control study. And you can see in the manuscript, they present exactly what their case definition was for each of these different type of endpoints of cases that were included in the study. So this is very, very detailed and very nice for people that come along later to be able to evaluate the study or to do something, or if they wanted to follow a similar method. It's very easy for someone else to follow a similar method if they wish. In terms of where can you identify cases, this depends very much on the topic of your study. People use different types of registries, cancer or disease registries, hospital records, insurance records, other records from the employer. Something that's important to think about, including in occupational epidemiology, is that you want to be careful that the probability of being identified as a case is not associated with your exposure of interest. So for example, if we have a case where more exposed workers may have more medical screening, maybe they're more likely to have your endpoint of interest disease diagnosed here. So something to think about. And often many people will use complementary data sources for identifying cases. So you may not just only use the cancer registry, you may also use death certificates or other information as well in your study. One of the most important, I think, points of the entire lecture today, I think, is that controls should originate from the same population as the cases. And that, if a control is selected, if, theoretically they had become a case, would you have also recruited them into the case control study? Controls should be selected independent of their exposure status, which is also an important principle here described in, this is one of the readings in the Moodle for the course. So these are four main principles that this reading describes for the selection of cases and controls and case control studies. So the first one here, cases and controls should originate from the same population and they should be representative of the same base experience. The second principle, deconfounding. So potential confounding factors should be controlled either in the design or in the analysis. And the third is accuracy. So we want to measure information on exposure with the same accuracy in cases and controls. And so these three principles are pointed out to help the researcher reduce selection bias, to reduce confounding, and to reduce information bias. And there's also the principle of efficiency in terms of how much does it cost the researcher for each unit of information that they collect. So this is an example again. Again, from the Interphone Interact study, just to give you a very brief background. So this was a 7-country study conducted as part of the Interphone study on brain tumors. We have different brain tumor cases here and controls. They were aged 30 to 59 years in most countries. And then for the participants, occupational history data was collected for over 35,000 jobs for these participants, including the job title, the name, the description, the start and the stop date. And so again, if you go back to this original methods paper, you can see that they describe very clearly what is the source population for the study. So if we look here in Ottawa, so they describe the source population for their study as being all residents of the study region at the time of diagnosis as a case or selection as a control. So to identify brain tumor cases in this study location, they had to go to many different sites, including different hospitals, where the treatment and diagnosis is centralized in these different departments. And then there were also, for the other less severe cases that were included in the study, they also had to go through to different medical doctors' offices scattered throughout the city to make sure that they captured all of the cases of interest in the study. You can see that fairly similar descriptions of source population for these other study sites. And where these different study sites recruited their cases. And if we look at the controls, so again, this is the exact same source population that I just described. And so for this study site, they used random digit dialing to recruit their controls. In these other study sites, they used electoral lists. And I think that these decisions were made for different reasons, including probably for efficiency, cost, and feasibility, which may be slightly different between these different study sites. I might skip over this since I'm a bit behind time, but we can come back to it if we wish. So something that's important to think about in terms of case control studies is selection bias. This was a paper published very recently looking at trends in participation rates in case control studies of occupational risk factors from 1991 to 2007. So here you can see this is the year that the data collection, the median year that the data collection was performed. And this is the participation rate of cases, and this is the participation rate of controls. And this is analysis of data from 189 occupational case control studies. And you can see that participation rates seem to be declining, both for cases and even more so for controls. So is this important to know? So this declining trend in studies, in this publication, they did not separate out population versus hospital controls in their analysis. But nevertheless, they note that participation is an important indicator of study quality. And as Neil showed on day one, even small biases can distort study findings. And because of this increased demand to participation in many cases for occupational case control studies, because of all of the work that's required to capture the occupational history data, participation may be more challenging to achieve here and could hinder future research in occupational risk factors. Then the authors note that maybe nested case control studies, case control studies nested in a cohort, may be a better design to think about if participation rates remain lower, continue to take the subgroup. Oh, thanks. You're already starting with the subgroup of participants that may be more willing to participate in further research in the future. So in terms of quantifying selection bias in your study, this is one really nice example. So this is again from the same Interphone Interoc study where they wanted to quantify the impact of selection bias caused by non-participation in this study. So they also noted declining levels of participation in case control studies, and they wanted to evaluate whether participation in the study was related to use of a mobile phone, because the mobile phone was the primary kind of research question for the study. And in many cases, they were required by their ethics board to introduce the study to potential participants as a study of mobile phone use. So, if somebody calls you and says, would you like to participate in a study of the health effects of mobile phone use, and you don't have a mobile phone and you've never used one, would you be more or less willing to participate? And so what they did here, for all the people that said that, no, I'm not interested to participate, I'm too busy, I'm not interested, they asked all these people if they could complete a shorter questionnaire. So instead of completing, the very, very long study questionnaire that full participants completed, they gave them just a very, very small, 5 or 10 question questionnaire, just to get a very minimal set of data on these non-participants in their study. So this summarizes the participants in the study. So here, if we look at, so these were the total number of controls, all of the eligible controls for the study. About 53% of them participated, and 47% of them did not participate. And these are the reasons for non-participation. Most were And you can see here for the cases, if we look at glioma cases, there were 4,000 cases of glioma that were eligible for participation in the study. 64% agreed and 36% declined to participate. There were different reasons for non-participation here, including in many cases that the subject was maybe too ill or had already died to participate. And so what they did here, so this is a breakdown, a more kind of detailed look at non-participation in the study. We can just look at the control arm. So as I already mentioned, there are about 14,000 target, controls. A little more than half were interviewed and a little less than half were not interviewed. Most of these people who were not interviewed refused to participate. And then out of all of the study centers in this multi-country study, some study centers wanted to capture information on these refusers. And among the study centers that did, they got information, a little bit of information about these refusers from over 1,600 controls. So that's 57% of the refusers in study centers that use the questionnaire. And same thing, they got information on over 100 cases here who had refused to participate in the study. And so these are the, so this is the case of controls. These are the cases in the study. So here we have the interviewed controls, and here we have the non-respondent questionnaire respondent controls. And so, they asked these controls a very small number of questions. And one of the questions that they asked them was, do you use a mobile phone? You can see here that controls who participated in the study were more likely to use a mobile phone than controls who didn't participate in the study. And the same thing actually for cases as well. So this is really an interesting and useful information to have as they're interpreting the results of their analysis. And you can do some very simple calculations, and you can estimate that this selection bias in their study would result in a downward bias of about 10% in the odds ratio for their study. So this is really, really useful information for interpretation of their findings. Of course, there are limitations of this approach. You can see that not all of the refusers and non-participants agreed to even do this short questionnaire. They may not be representative of all refusers. They may not be generalizable. And they're different, and not all of the study centers use this non-respondent questionnaire. So it may be, an interesting thing to think about if you are currently recruiting participants to collect a little bit of information on the non-participants, if you can, especially related to your main study hypothesis. Something else this paper points out also in terms of selection bias in case control studies of occupational risk factors. They point out that, if you're recruiting your cases and you want to focus on maybe large urban hospitals and possibly not worry about cases at smaller, maybe more rural hospitals for logistic reasons, these hospitals serve very different communities, and the occupations of the people who go to these hospitals may be very different. So it's an important type of bias to keep in mind. Deconfounding. So in this study of brain tumors, we already know that there are very few established risk factors for brain tumors. So what they did is they conducted some matching on important confounders such as age, sex, and study center. Here to address potential confounding. In terms of accuracy, so again, here we have, these are the number of cases of glioma cases recruited in all of the different study centers. So in total, over 2,000 glioma cases were recruited. And here you can see this is the median delay between diagnosis of the case and interview of the case. So most cases were interviewed a few months after their diagnosis, in some cases many months after diagnosis, some more than 6 months after their diagnosis. And this is really important information as well when you're thinking about glioma cases in terms of their health and ability to respond in a type of demanding interview. And then here we can see information on the mode of interview and how it may differ between cases and controls. So here, what's I think interesting to point out is that, the cases, because of their poor health status, often were much more likely to use a proxy respondent. So maybe a family member, maybe a spouse, a friend, to help them or to respond entirely to the study questionnaire for them. Compared to cases. So when we think of accuracy and we think of similarity of collecting exposure information between cases and controls, do you think that the information collected here from cases and controls is similar, or is it similar enough for the study to be valid? And of course, you can do analysis excluding proxy respondents as well. But just something to think about, and every endpoint is very different. It's very different here. This is maybe one extreme example, but it's really nice, I think, how this study collected and presented a lot of really detailed information on these really important study characteristics in this methods paper. Something else that's interesting to think about too is that, this was a study primarily of mobile phones, and you can see, the really rapid increase of mobile phone use. And this was the main study period. And so between 2000 and 2004, you can see a huge increase in the change of use of mobile phones in the population. And you can also think of, in terms of occupational epidemiology, you may think maybe more so now, maybe there could be large decreases, for example, in the exposure of people on the topic that you're interested in studying. So when you're thinking about recruiting participants and including, when are controls recruited compared to the cases, it's really important to think about that carefully in the context of a rapidly changing exposure situation. So this is one paper we did in the context of this study of mobile phone use, where we recognized that the data was collected during this period of rapidly increasing phone use. And what we did is, what we wanted to do is we wanted to rematch the cases and controls, the cases to controls based on their interview data in a kind of a much more careful way to see what kind of impact that would have on the study findings. So this were and five countries participated in this analysis, and these are the main findings. Again, here you can see this kind of decreased odds ratio for the main association between ever use of a mobile phone and glioma risk with the original matching. And then when we rematched the studies, you can see it had a very small impact. You can see here that this odds ratio increased a little bit. You can see that the odds ratio in the highest categories of use and sometimes in the kind of second last category of use also increased. So it made a little bit of a modest kind of impact on findings. Not a lot, but a modest impact. And I think it was worthwhile exploring this question in detail. So just to emphasize again, the need for, rapid ascertainment of not only the case, but also the control participants when your exposure pattern may be rapidly changing. And then the fourth principle was efficiency. And so in this study of brain tumor use, what they did is they designed these different modules on specific types of occupational situations that they thought, that they had some information to hypothesize it could be useful to examine here in this study. So for example, if you had ever worked, this is an example of communication devices. So if you had ever used different types of, radio communication devices at your work, if you answered yes, then you were automatically asked these more detailed questions in this module, and there were all these different modules here. So, and this was a very simple module. Some of the other modules are much more complex. So again, just to emphasize the type of detailed exposure information you could collect in this type of study. So in terms of population-based case control studies, one of the reasons that they're often cited as being nice is that, you can examine a range of occupational exposures by collecting information on a range of people throughout the entire population. It can be difficult sometimes to recruit, to ensure that the cases and controls maybe have the same chance of selection, that the quality of information that's captured from both cases and controls is similar, maybe more expensive, and response rates may be lower in the general population. This is another maybe weakness or disadvantage of general population case control studies. This is based in the same interphone study. This is one paper we did looking at solvents again and glioma risk. And so this is the total number of controls, men and women combined here. And then here you can see the percentage ever exposed. And you can see for many of these solvent exposures, there was either zero controls, ever exposed, or very, very small percentages of controls ever exposed. So that doesn't give us a lot of information to conduct our analysis of risk associated with these different exposures. So another limitation to consider, and to consider what populations you might conduct your studies in. You can also use neighborhood controls as well. This can be a little bit complex when you're thinking of residents moving in and out of the neighborhoods. They also note here that you have to be very careful of possible bias from the interviewers, maybe selecting residences that may appear more likely to cooperate. So some careful work there is needed. There are some disadvantages here. I think, multi-unit dwellings, documentation of non-response, I think is very complex. There's a notion that you may be overmatching people, that their exposure situations and profiles may be very similar to each other. Maybe too similar to each other here. Random digit dialing, we've already mentioned. This has been used in different studies, mainly in the past and more so in North America. And again, this is very costly. It usually requires a lot of telephone calls to get a participant. And now, this paper was written kind of before the mobile phone use explosion, and now with the use of mobile phones and people having multiple phone numbers, personal phone numbers, household phone numbers, or no household phone at all. I don't know if random digit dialing is very, very practical anymore in many settings. So this is an example of a study in Barcelona that was done. And what they wanted to do is they wanted to recruit 40 controls, but it took them 180 phone calls. And it took them an average of 2.8 phone calls just to get one person to answer the phone. And then to get one person to agree to participate took about 6.5 phone calls. So that's, it's a lot of work, and it's expensive to pay for this work. We also have hospital controls. And so this paper, and so when you're selecting hospital controls, it might be much more convenient, to collect information from cases and controls from a main hospital, for example. I think it's really important to consider that, the controls that you are recruiting into your study, to ask yourself, if they had become a case, would have they been diagnosed at that same hospital? I guess that, there's different referral patterns for different types of diseases. And that's something very important to consider, especially, in a setting where there are multiple hospitals. This paper also recommends, it's important to recruit controls with diseases from hospitals that are not associated with the exposure under study. And they also recommend that you could consider recruiting controls with multiple different diseases. So that way, if maybe one of the control disease groups, is if you're uncertain about its relationship with the exposure under study, at least you have all of these other controls with other diseases that are probably not related with the exposure under study. So that's just something that they suggest you can think about. Here's an example. So the Interphone Interrock study was conducted in adults. And then a few years later, they conducted a similar study on mobile phone use and brain tumors in children. And so here they recruited all of the cases through contact with these different hospital units, as well as review of the cancer registry and hospital discharge records. And what they decided to do in this study, instead of selecting general population controls, because they had a lot of evidence that the response rate was going to be low, and they wanted to avoid selection biases as much as possible, they decided to use hospital controls for children who had an appendectomy for suspected appendicitis during the same study period. And they had much higher participation rates among these hospital controls. And some study centers collected both general population and hospital controls and very clearly demonstrated that. And they felt fairly confident in their selection because this is a very common disease, which is unrelated to their main exposure of interest. And so again, there's different advantages and disadvantages to the hospital-based case control design. And I think, really considering very carefully the referral patterns to the hospital that you may be working in is a very kind of key piece of information. Key point to consider carefully. Hospital controls may also be very useful when you're interested in collecting information on biological samples, blood samples, urine samples, different samples. They may be more willing to offer those samples to you. So something else to consider there, depending on your question. So this is an example from some work in Spain on biological samples. And so here you can see that in this population-based study, this is a study on respiratory disease that Neil and Manolis were involved with. You can see, actually, this is not bad. They had a response rate, about 85% response rate for the questionnaire, but only a 55% positive response rate when they asked if they could take a blood sample among the participants. In contrast, this is this other study that was done in Spain using a hospital-based design. Again, they had about an 85% response rate to the study questionnaire. And then when asking these people if they'd be willing to give a blood sample, almost all of them said yes. So this is an important thing to consider if blood samples or biological samples are important for your research question. I wanted to show this study as a recent example of a very nice piece of work pooling different case control studies from all of these different countries. So from 14 different countries together. This paper was published last year, I believe. So this is a series of papers looking at lung cancer risk and different types of occupational exposures. And just to highlight, pooling all of these studies, the very large number of lung cancer cases and lung cancer controls that they were able to study. Again, here they had some studies used population controls, some studies used hospital controls, and they had so much information too that they were also able to compare the results using these two different designs. And you can see here for the analysis using hospital controls, a slightly weaker association. You can see here between silica exposure and lung cancer risk. So possibly, it'd be interesting to look into those hospital controls and to see exactly what type of diagnosis they had And are these diagnoses possibly related to the exposure of interest in the study? So it's great that they were able to consider this type of stratified analysis here. Maybe I'll just skip that. And this is a paper that Neil mentioned on Tuesday as well. So this is another interesting study design of occupational cancer. So in this study, what they did is this paper was interested in looking at colon cancer risk. And in this study, they had information on colon cancer cases, but also on people with cancer at 18 other sites. So they had 19 different types of cancer cases in their study. They also had a smaller number of population controls. And so they did the analysis different ways. They did the analysis using either comparing the male colon cancer cases to the population-based controls, but they also compared the male colon cancer cases to the other cancer controls. And they did this different ways. One way was excluding the lung cancer cases from the control group, because it's known that there are many strong associations with workplace exposure and lung cancer risk. Another way they did the analysis was excluding subjects with cancers of the digestive tract, which may have common risk factors to colon cancer, which is the cancer of interest here. But overall, they concluded that they found generally similar results using any of these different control groups. So maybe it's another option for you, depending on the research topic that you're working on. So key points of case control studies: a major advantage is that they save time and expense relative to cohort studies in many cases. And you can collect very detailed information on occupational exposure. So here we've gone through different types of case control study designs, but there are other designs as well. And we've also gone through a description of some of the types of biases that can be present in some of these studies, and also maybe some potential solutions to examine some of these biases in these studies. So that is the end of the slides. I'll stop sharing my screen.